Good morning, ladies and gentlemen. I am Professor Ashar Ahmad Mashood. Please subscribe to my channel if you are hearing my video. So today's topic is graft versus host disease. Definition. The graft versus host disease is a multi-organ disease process that results from the action of donor-derived immunocompetent T lymphocytes against the antigens expressed on the cells of immunocompromised recipient host. So, this is a reaction process due to the immunocompetent T cells which are infused into an immunocompromised host at the time of hematopoietic stem cell transfusion. And the main organ which are affected in graft versus host disease are skin, GI, and liver. GVHD is the major complication of allogenic hematopoietic stem cell transplantation with an incidence of 25 to 80%, which is quite a handsome incidence. The exact risk depends on factors such as HLA disparity between the donor and the host, the conditioning regimens which are given prior to HSCT, and the GVHD prophylaxis used. The GVHD also occur after transfusion of donor lymphocyte infusion, solid organ transplant, and maternofetal lymphocytes engraftment. So in addition to HSCT, graft versus host disease also occur due to donor lymphocyte infusion, solid organ transplant, and maternofetal lymphocyte engraftment. There are two major forms of graft versus host disease. The acute one, which present within first 100 days of HSCT, and chronic graft versus host disease, which occur after 100 days of HSCT. Then there is acute or chronic GVHD, which is an overlap syndrome with features both of acute and chronic GVHD, and progressive GVHD, where the acute lesions progress directly to the chronic stage of GVHD. Hematopoietic stem cell transplantation, which is the main reason of GVHD. In this process, allogenic hematopoietic stem cells, which are derived from the bone marrow, peripheral blood, or umbilical cord, is used widely for treatment of various hematological malignancies, also for immunodeficiencies and marrow failure syndromes, like aplastic anemias. The process is increasingly being utilized for other life-threatening conditions like multiple sclerosis, Crohn's disease, SLE, and systemic sclerosis. GVHD is the major cause of morbidity and non-relapse related mortality in such patients. And in most common sites affected by GVHD is the skin. The risk factor for GVHD. As mentioned, the HLA mismatching and use of unrelated donors confers as the major risk factor. Other risk factors include the gender mismatch, a total body irradiation, older recipient more than 40 years, patient with already having a history of acute GVHD, splenectomy in the recipients, Epstein-Barr virus donor seropositivity, and other risk factors like donor alloimmunization, that is, previous pregnancy or transfusions, and administration of donor lymphocyte infusion following allograft. Pathogenesis. The acute graft versus host disease arise as a result of three-stage process. Stage 1 is the toxicity from conditioning chemotherapy or radiotherapy, which occurs before the HSCT. It causes tissue damage to the host that results in release of several inflammatory cytokines. Then the second process is now when HSCT is done, the mature donor lymphocytes from the graft are recruited by these cytokines, which are already generated because of conditioning chemotherapy or radiotherapy. This leads to activation and proliferation in contact with activation and proliferation of donor lymphocytes in contact with the donor antigen presenting cells. The third step is these alloreactive T cells expand to form cytotoxic T cells, causing now these cytotoxic T cells cause further damage in the recipient tissue and release more inflammatory cytokines. After the first three steps in pathogenesis of acute GVHD, there is thymic disruption as well, enabling the autoreactive and alloreactive Th17 cell production. Elevated level of B cell activation factor, BAF, have been detected, and the donor-derived B cells play a role in GVHD pathogenesis, triggering further auto and allo antibody production. Furthermore, reduced peripheral regulatory T cells due to thymic dysregulation and exogenous calcineurin inhibitors reduce the immune tolerance. So if I would like to summarize the pathogenesis of acute graft versus host disease, it is actually a reaction between the immunocompetent T cells against the cells of immunocompromised host. And this occurs first by generation of cytokines due to the conditioning chemotherapy or radiotherapy before hematopoietic stem cell transfusion. And once we perform this procedure, that is hematopoietic stem cell transfusion, the mature T lymphocytes comes in contact with these inflammatory cytokines, and these inflammatory cytokines result in activation and proliferation of these mature T cells in contact with the donor antigen presenting cells. So these T cells then produce the effector T cells, and these effector T cells will result in damage to the recipient tissue. In addition, the B cell activation also occur, producing the auto and allo antibodies. And due to this reaction, there is thymic disruption, as a result of which the regulatory T cells production is reduced. And these regulatory T cells have a role in immune tolerance and reducing the immune reactions. But since they are less due to thymic disruption, the graft versus host disease reaction amplifies. And organ fibrosis as a basis of GVHD. The damage to the endothelial cells allow the donor cells to migrate to the organ. So through the blood vessels, the donor cells move to the organs. Macrophage transforming growth factor beta production again stimulates auto and alloreactive antibodies and then activates fibroblast and induced aberrant collagen production. Hence, end organ fibrosis occur, leading to the clinical manifestation of graft versus host disease. GVHD prophylaxis. The GVHD prophylaxis is done with oral tacrolimus or methotrexate before HSCT, as does the use of reduced intensity of pre-procedure conditioning. So if we do these procedures, the incidence of GVHD is reduced. Now, histopathology. As far as the acute graft versus host disease is concerned, its picture is similar to the interface dermatitis. And as you can see, there is basal cell vacuolar degeneration. Apoptotic keratinocytes are seen, a few 1 and 2 are seen as well. There is no band-like infiltrate, but there is perivascular lymphohistiocytic infiltration in the upper dermis. You can see in this picture, there is pigmentary incontinence and single cell necrosis or apoptosis is also seen. And this picture with a split as well, this picture is reminiscent of 10. A slightly extensive lesion with vacuolar degeneration, interface change, focal cell necrosis, colloid body formation. Histopathologically, the acute graft versus host disease is classified into 4 grades. In grade 1, there is focal or diffuse vacuolar degeneration of basal cells. In grade 2, along with the vacuolar degeneration, there is spongiosis and slight bit of dyskeratosis. While in stage 3, there is subepidermal cleft, while in stage 4, there is complete loss of epidermis like we see in 10. Then the histopathology of chronic graft versus host disease is much similar to morphia. The epidermis is flattened and atrophic, and the dermis is thickened and fibrotic. Epidermal appendages are lost and very much looks like morphia. The clinical features of acute graft versus host disease. This often occurs 2 to 4 weeks after HSCT, but can present any time after transplant. Hence, acute GVHD is described to occur before 100 days of transplant. Pruritus or burning are usually the first symptoms which precede the skin eruption, and patient may also report with oral and genital ulceration. There is typically red blanching macules develop on palm and soles and ear, as you can see in this picture. The eruption may appear at the photoaggravated sites, affecting the neck, upper back, and face, and sometimes they may be folliculocentric. As GVHD evolves, it becomes very similar to 10, with more confluent morbilliform rash, and in severe cases, there is generalized erythroderma, bully and extensive Nikolsky sign positive epidermal skin loss, and 10-like picture. You can see the skin loss here and a generalized diffuse morbilliform rash. Orally, xerostomia, redness, and ulceration occur, but it is difficult to distinguish this feature from chemotherapy-induced mucositis. Then there may be profuse diarrhea that point to GI involvement, as do the symptoms of nausea, anorexia, vomiting, and abdominal pain. The cholestatic symptoms include pale urine, dark stool, and right upper quadrant tenderness pointing towards the liver involvement. Glucksberg staging system, or the classification of severity in acute graft versus host disease. We will discuss this system organ-wise, the skin, liver, and gut. So as far as the skin staging is concerned, maculopapular rash involving less than 25% of the skin is grade 1, severity 1. Then 2 is the maculopapular rash over 25 and less than 50% of the body area. Then grade 3 or stage 3 is generalized erythroderma. Stage 4 is generalized erythroderma with bully formation and desquamation. Liver manifestations are also stage 1, having a bilirubin of 2 to 3 milligram per deciliter and SGOT 150 to 750 international units. Then stage 2 is 3 to 6 milligram per deciliter. Stage 3 is 6.1 to 15 milligram per deciliter, and stage 4 is more than 15 milligram per deciliter. Then gut. Stage 1 is diarrhea of greater than 30 ml per kg and greater than diarrhea of 30 ml per kg or 500 ml per day. Stage 2 is diarrhea more than 60 ml per kg or more than 1000 ml per day. Stage 3, diarrhea more than 90 ml per kg or 1500 ml per day. Stage 4 is great diarrhea more than 90 ml per kg or more than 2000 ml per day with severe abdominal pain with or without ileus. Then International Bone Marrow Transplant Registry Severity Index of acute graft versus host disease. The severity is highest level when patient reaches based on separate skin, liver, and GI scoring system. So the stage A is stage 1 with the skin involvement and no liver or gut involvement. And stage 2 or B is skin involvement with stage 1 or 2 of gut or liver involvement. Stage 3 and 4 is having skin, liver, and gut involvement. Complications and comorbidities. Oral ulceration and diarrhea may lead to weight loss and dehydration. Skin erosions may lead to secondary infection. The transplant-related mortality vis-a-vis the staging of acute GVHD. In stage 0, it is 28%. In stage 1, it is 27%. In stage 3, it is 43%. Stage 2 is 43%. 3 is 68%. And stage 4 is 92%. Investigations. Diagnosis of acute GVHD is challenging and is based mainly on the clinical findings. Skin biopsy lends support to the clinical signs, and peripheral eosinophilia may also be present. Prognostic biomarkers. The prognostic biomarkers of AGVHD is elafin, which is a keratinocyte-derived protein that is overexpressed in skin in cutaneous GVHD. Then ST2, or suppression of tumorigenicity 2, an interleukin-1 receptor family protein, predict response to treatment in AGVHD. Management. For grade 1, acute graft versus host disease confined to skin, with less than 50% of the body involvement, topical corticosteroids and emollient is recommended, along with optimization of ongoing prophylactic GVHD immunosuppression. Adjuvant antihistamine therapy may help in patient with itch, and topical tacrolimus ointment is useful in refractory grade 1 acute GVHD. Then the treatment ladder for stage 2 to 4 disease. The first line is corticosteroids, prednisolone 1 milligram per kg or IV, oral calcineurin inhibitor like cyclosporin or tacrolimus. Second line treatment include extracorporeal photopheresis, mycophenolate, mofetil, an mTOR inhibitor, or, for example, sirolimus. Third line include mesenchymal stromal cells, L-mutuzumab, and pentostatin. Further treatment or trials are going on for T-regulatory adoptive immunotherapy strategies, itolizumab, which is anti-CD6, bortezumab, which is a proteasome inhibitor, and maraviroc, which is CCR5 antagonist. Chronic graft versus host disease. This occurs 100 days later to HSCT. It can present before 100 days. It may occur de novo with no prior acute GVHD, or quiescent occurring after a long period from AGVHD or after its inactivation or resolution, and progressive, in which AGVHD rapidly turns into chronic GVHD. Skin is the most common site involved, followed by mucosa, but virtually any organ can be affected. Clinical features. This disease has insidious onset of dry, itchy, and tight skin. There is ocular and oral discomfort and dryness, vulvovaginal dryness, itch, and discomfort. The GI symptoms include nausea, diarrhea, and vomiting. Respiratory symptoms include shortness of breath. Musculoskeletal systems include muscle weakness and limited range of movements. The summary of clinical variants of chronic graft versus host disease. The cutaneous reactions are epidermal, like eczematous rash, the papillosquamous rash, and PRP-like rash, having one case report. Then there can be lichenoid rash, there can be sclerotic rash, like sclerodermoid rash with deep sclerosis and eosinophilic fasciitis-like skin. Then LSA-like or morphiform-like rash. Other changes include ichthysis, hyperpigmentation, hypopigmentation, keratosis pilaris, poikiloderma, and erythroderma. You can see this hyperpigmented but sclerotic lesion seen on the side of the trunk and on the leg. Associated feature. Oral lesions include lichenoid rash, microstomia, mucocele, Zika syndrome, and verrucous xanthoma. Hair includes scarring and non-scarring alopecia. Nail may be dystrophic. There is anonychia and trigium formation. Ocular and genital mucosa is associated with erosions, pain, lichen planus, or lichen sclerosis-like lesions. Extracutaneous manifestations like in AGVHD is mainly GI and liver. In addition, lungs, musculoskeletal system, leading to fasciitis and myositis and other demyelinating conditions. Differential diagnoses include the lichenoid eruption, the radiation-induced fibrosis, and skin sclerosis and more. Scoring system. Score 0, no symptom. Score 1, less than 18% of body surface area, but no sclerotic change. Score 2, 19 to 50% of body surface area with superficial sclerotic features, but patient ability to pinch. Grade 3 is more than 50% of body surface area involved with deep sclerotic features, hide-bound skin, unable to pinch, impaired mobility, ulceration, and severe pruritus. Complications and comorbidities. The sclerotic disease and facial contractures lead to severe limitation of movement and disability, along with other issues such as difficult venous access. Then dyspigmentation and poikiloderma can cause profuse change in appearance. The psychological burden of chronic GVHD and its impact on quality of life can be underestimated in patients who already had to cope with the impact of malignancy and allogenic transplantation. Disease course and prognosis. Chronic GVHD is a major cause of morbidity and mortality in long-term survivors of HSCT. Severity grading predicts the prognosis. Chronic GVHD is associated with high treatment-related mortality post-allogenic transplant despite a slightly low rate of disease relapse. Overall survival at 2 years is 97, 86, and 62% with patients of mild, moderate, and severe chronic GVHD. Treatment ladder. The first line is again corticosteroids, 1 milligram prednisolone per kg or IV, oral calcineurin inhibitors, or cyclosporin as a steroid-sparing agent. Second line include extracorporeal photopheresis, rituximab or imitinib, or ruxolitinib, and then pentostatin. Third line treatment include mycophenolate mofetil, high pulse dose steroid, methotrexate, sirolimus, ibrutinib, or other brutonotyrosine kinase inhibitor. Other therapies include hydroxychloroquine, clofazimine, cyclophosphamide, elmutimizumab, which is anti-tumor necrotic factor antibodies, thalidomide, alfacept, retinoids, azathioprine, and mesenchymal stem cell. The further treatment options are ixozimib, a proteasome inhibitor, and blomoxudil, which is ROCK2 inhibitor. So this brings me to end of my talk. I thank you very much for patient listening and see you next time with another topic. Have a good day and goodbye.